Good evening, everyone. My name is Kathy Flynn, and I am the National Senior Director of Engagement at the American Liver Foundation. It is my great pleasure to welcome you to the academic debates presented by the Southeast Medical Advisory Council. This educational program is the result of the dedication and the efforts of our 2021 co-chairs, Dr. Andreas Zori and Dr. Raj Satyanarayana, with influence from the Southeast Medical Advisory Council members. We are excited about our 4 debate topics, proud of our teams, grateful to our sponsors, and honored to have such an outstanding panel of judges alongside our esteemed moderators. We're grateful that you're taking time out of your busy schedule this evening to join us, and we hope you enjoy the program. Since this is a virtual event, we are unable to host our pre-debate reception that so many of us enjoyed in 2019. So before the educational component of the evening begins, we will spend a few minutes in a virtual debate reception. The Southeast Debates event is being delivered on the Zoom webinar platform and is being recorded. During the presentations, if you have a question, please hover your mouse over the bottom of your screen and click on Q&A. Then simply type your question into the Q&A box. For all other comments and to cheer on your team, please use the Q&A box as well. We'd like for this event to be as interactive as possible, so feel free to let us know who you are and where you're from, and be generous with your shout outs to your favorite team. Remember, please use the Q&A function because the chat feature will not be used this evening. Once more, please note that this program is being recorded and will be available on ALF's YouTube channel for on-demand viewing. A very special thanks to the members of the American Liver Foundation Southeast Medical Advisory Council who dedicate themselves to liver patients and caregivers throughout Florida, Georgia, South Carolina, and North Carolina. This cohort includes an impressive list of liver experts who guide us as we fulfill our mission. A special thank you again to our co-chairs of the Southeast Academic Debates, Dr. Andreas Zori and Dr. Raj Satyanarayana. Before I introduce our moderators, let me pause to acknowledge our technology team, Barb Potter and Karen Irwin, and the newest member of ALF's engagement team, Nancy Clemens. They are the tech experts coordinating things behind the scenes this evening, and I could not be more grateful for their assistance. The 3rd annual Southeast Academic Debates will offer continuing medical education credits to physicians who are eligible. Allied health professionals who wish to receive credit for their attendance may present their participation certificate to their affiliated association to request their credit. In compliance with the ACCME guidelines, there will be no involvement with or mention of any commercial support during the educational portion of the program. So instead, before the actual debates begin, we acknowledge their support of the American Liver Foundation's mission to promote education, advocacy, support services, and research for the prevention, treatment, and cure of liver disease. All registered attendees will receive information regarding the CME process via an email, which will include details. The American Liver Foundation is grateful to our national and our regional sponsors. National sponsors that are supporting the academic debates across the country this year include our national gold sponsors, AbbVie and ASI, our national silver sponsor, Salix, our national bronze sponsors, Alexion, Mallinckrodt, and Pfizer. And locally, we recognize the support of our Southeast bronze sponsor, Intercept. We are so grateful that so many of our national and local partners were able to be in attendance with us in the audience this evening. Thank you so much for joining us. And now we'd like to share some brief video messages from our national gold and silver sponsors.
Right now, millions of patients are suffering with GI disorders such as overt hepatic encephalopathy, irritable bowel syndrome, chronic idiopathic constipation, opioid-induced constipation, bowel preparation, and ulcerative colitis. At Salix, we have kept up with these unmet needs for more than 30 years by providing an industry-leading portfolio of high-quality products that address these conditions. Through our dedicated and innovative R&D team, we're also exploring potential new scientific breakthroughs, and we remain committed to important healthcare provider investments in education, charitable grants, and sponsorships. We will continue to invest millions of dollars in patient education and do our best to broaden access to Salix medications, because our mission to improve the care for GI patients continues today. For us, there is no finish line.
Thank you once again to our sponsors for their support of the American Liver Foundation. This concludes the virtual pre-debates reception, and we are ready to move on to the educational program portion. So now it's time to turn the program over to two well-respected members of the Southeast medical community and our moderators, Dr. Andreas Zori, a gastroenterologist and transplant hepatologist at the University of Florida Health in Gainesville, and Dr. Raj Satyanarayana, a gastroenterologist and transplant hepatologist from Mayo Clinic in Jacksonville. These two dedicated physicians devoted countless hours over the past several months to plan this event. I could not be more grateful for their professional guidance and input.
Good evening, everyone. Thank you for joining us. It's been my pleasure to serve as this year's co-chair of the American Liver Foundation Southeast Academic Debates, along with my colleague, Dr. Raj Satyanarayana. Before he takes over, I will first review the format of the evening and talk about the American Liver Foundation. Tonight, we will host 4 exciting debates featuring teams from Florida, Georgia, South Carolina, and North Carolina. The topics we're assigned to debate are chosen specifically because they have not been settled in the medical literature or are ethical in nature, with no right or wrong answer. Through these debates, we seek to stimulate higher thinking about significant issues that impact the lives of people with liver disease. The debates will be fast-paced. We will start each debate with a pro presentation, followed by the opposing con presentation. Each slide is allotted precisely 6 minutes to present their argument. Should a presenter exceed his or her 6 minutes, our diligent timekeepers will disconnect his or her audio and video. We will do our best to transition smoothly from one presenter to the next to keep the program flowing. After both arguments have been presented, each side will have the opportunity to challenge their opposition with a 3-minute rebuttal. Debate teams may not use slides during their rebuttals. Teams will be closely timed. A 5-minute question and answer session led by a panel of judges will follow the rebuttals. The debate teams will be judged on the following criteria: presentation, content, and organization, presentation and rebuttal skills, use of research supporting their position, responses to questions, and overall style and digital delivery. Hopefully, the debates will stimulate greater passion and enthusiasm for the field of hepatology, ultimately leading to improved care for liver patients. We want this debate to be interactive, so please use the Q&A feature to pose questions to the debate teams. If time permits, following the judges' questions, we will bring your questions forward. After each debate, the 3 judges assigned to that debate will meet privately to discuss the score of the teams. To avoid bias, none of the judges are assigned to judge debates from their home institution. At the conclusion of the 4th and final debate, we will announce the winners of each debate. We will also poll the audience to determine the People's Choice team this evening. Before I turn the program over to my co-chair, Dr. Raj Satyanarayana, I would like to say a few words about the American Liver Foundation. The ALF's mission is to promote education, advocacy, support services, and research for prevention, treatment, and cure of liver disease. Across the country, the ALF serves patients, caregivers, and healthcare professionals. Throughout the evening, we will share information about how the ALF is furthering their mission, working towards a world without liver disease, and how we can support their efforts. The ALF is a non-for-profit advocacy organization. As such, relies on donations to carry out its mission. I invite everyone in the audience to make a personal donation to help the ALF continue to provide education, support services, research, and advocacy resources to the liver community and the general public. Please be as generous as you can. As many of you know, the American Liver Foundation is celebrating its 45th year. Despite the pandemic and due to the resilience of the ALF staff, stakeholders, local leadership, and our industry partners, we stand strong in our commitment to provide resources to the liver community. Please consider joining us, either in person or online, for the ALF's 45th anniversary Legacy Gala on October 21st, 2021. And please be sure to use social media throughout the evening and follow the debate's Twitter feed through our program at ALF Debates. And remember to cheer for your favorite team by posting a message in the Q&A feature. Note that the chat function will not be used, but the Q&A is there for you to use. To include an interactive component for our audience, this year we have added an audience polling throughout the evening. Questions will be posted periodically, and we're hoping you will take a moment to respond. The poll results will be shared via email within the next day or so. The Southeast Academic Debates have been hosted by the ALF Southeast Medical Advisory Council since 2019. We are honored that the academic debates have been recognized for its excellence and have become a signature program of the American Liver Foundation and the AASLD. And now, without further ado, and while you're considering making a gift to the ALF, I'm pleased to introduce my co-chair for this year's Southeast Academic Debates, Dr. Raj Satyanarayana.
Thank you, Dr. Zori. I am delighted to serve as a co-chair and co-moderator this year. Before I introduce our first topic and team members, it is my privilege to introduce our outstanding panel of judges. We have a total of 6 judges with us this evening. 3 judges will be assigned to each debate and will join us on screen at the conclusion of their assigned debates to ask thought-provoking questions of our debate teams during the Q&A session. To be fair, judges from participating institutions are not assigned to debates in which their institution is competing. Our judges for debate numbers 1 and number 3 are Dr. Joydeep Chakraborty from University of Mississippi, Dr. Ayman Kotesh from Advent Health, and Dr. Miguel Malespin from Tampa General. Our judges for debates 2 and 4 are Dr. Joe Morelli from the University of Florida in Gainesville, Dr. Tushar Patel from Mayo Clinic, Jacksonville, and Dr. Andrew Keaveney, also from Mayo Clinic, Jacksonville. Thank you to our esteemed panel of judges. And now, the moment you've all been waiting for, the debates. Let's begin with the first debate. Debate number 1 will be judged by Dr. Chakraborty from the University of Mississippi, Dr. Kotesh from Advent Health, and Dr. Malespin from Tampa General. Just as a reminder to the debaters, each team is allotted precisely 6 minutes to present their argument and 3 minutes for rebuttal comments, and following the debate, a 5-minute question and answer session. Debate number 1. A 65-year-old man with chronic hepatitis C, who is a sustained virological responder, yet has cirrhosis complicated by ascites requiring paracentesis every 2 to 3 weeks and hepatic encephalopathy requiring hospitalization 3 times in the past 6 months, despite compliance with lactulose and rifaximin, is listed for liver transplantation. His med score has been stable at 17 with a mean mailed at transplant at his listing hospital of 25. He is negative for hepatitis B surface antigen, surface antibody, as well as core antibody. He should be listed for HBV DNA or hepatitis B surface antigen positive donors. The pro augment will be made by the University of Florida in Gainesville, and the con position will be Mayo Clinic, Jacksonville. Now let's meet the debate teams. Presenting the position that this patient should be listed for a hepatitis B viral DNA or hepatitis B surface antigen positive donors is University of Florida, Gainesville. The team's mentor is Dr. Cabrera, and the debate team members are Dr. Media and Ismael and Dr. Kiani. Mayo Clinic Jacksonville will be presenting the con position. This patient should not be listed for HBV DNA or hepatitis B surface antigen positive donors. The Mayo Clinic team mentors are Dr. Nicole and Dr. Surakit Pungpapong. The debate team members are Dr. Pedro Palacios Argueta and Dr. Ghali Vora. In order to gauge the audience's perspective before they hear the debate, we will ask them about their perspective if the patient should be listed for HBV DNA or hepatitis B surface antigen positive donors. We will then also follow up with a post-debate poll to assess the impact of the presented arguments. Dr. Kiani from the University of Florida, Gainesville will now present the pro position. Timekeeper, ready. Let's begin.
Okay, good afternoon, everyone. My name is Calvin. I'm one of the fellows at the University of Florida, Gainesville, and I want to thank everyone for inviting me for this presentation. So my team is me and Dr. Ismael, and we're going to talk about transplanting Hep B positive organs to Hep B negative recipients. So there are close to 107,000 men, women, and children transplant list, and every day close to 17 people die waiting on the list. That's close to 500 people per month. That's more than 2 airplane crashes just because of accidents. If you just want to compare, that's a huge number. And you're transplanting close to 33,000 organs per year. So we are not doing a fantastic job. We need to enlarge our donor pool. This is the UNOS map of the United States, as you can see. And this is the median melt all over our country that people get transplanted at. And if you look at this region, which we are practicing hepatology and you're listing people, the median melt is higher than our patient in this stem, much higher actually. And if you look at the percentage of people who are listed and get transplanted at the melt that our patient is at right now, it's 17, so it would fall into this range. The chances are not so great for getting transplanted. Some might think if the patient stays on the list for 2 years, has like 50% chance. But our patient has decompensated cirrhosis, which the median survival is less than 2 years. And as a child C, which our patient is, the 1 year survival is 45%, 2 years less than 35%. So we do not have the luxury of time. Time is precious, and we're losing that by just waiting on a transplant list. Another dangerous but significant trend is people who are 65 and above, as you can see in this slide, are becoming more and more on a transplant list. This is patients 65 and above. And people with the MELD of 15 to 25 are getting listed more and more compared to other groups. And what is really concerning is that if for whatever reason, people who are 65 and above get delisted because of whatever happens to them, they have the highest mortality rate on a transplant list, off of the transplant list. And these are some of the outcomes that can happen in people such as our patient with the MELD between 15 to 22. As you can see, one of the major things that we are concerned about is death on wait list, and patients in this MELD group have close to 22-23% chance of mortality while waiting. So where do we stand with using Hep B positive organs? If it's an isolated anti-Hep B core, it's almost unanimous that we can use them. The risk of transmission is mainly liver transplant. The other organs are negligible, and it can actually be used in all transplant candidates based on the most recent guidelines. When we go from Hep B core to Hep B antigen positive, it's a very different story. So from Hep B positive to Hep B positive, some of the most recent guidelines suggest that it can be used in urgent non-renal transplant candidate with some treatment, and it can also be considered an endemic area when there's a really high prevalence of Hep B positive organs. When it comes to Hep B positive donors to Hep B negative recipients, it's we don't really have much data. There's scarce data, but even the data from these small studies show that the outcomes are not affected by donor Hep B surface antigen status. And just to emphasize on how small that data is, or the patient population, if you look at this table here, donor positive, recipient negative consists close to 0.1% of all the Hep B recipients for liver transplant. One of the biggest studies to date is this one from Lee et al. That was published in 2014. They looked at 63 Hep B positive donors that the liver was transplanted in Hep B negative patient population. And as you can see here, the patient survival was very comparable. There was no significant difference at all. And the graft survival was very, very similar as well. So this is one of the largest studies to date. And we know they do very similar. Another good study is from Sadie et al. From a couple of years ago. They followed up patients, 24 patient Hep B related disease that went to Hep B negative patients, and all allograft and survival was again very comparable between the two groups. So we know we have some data, they're promising, but what are we afraid of? What are our major concerns when using Hep B positive organs in Hep B negative people? So is it ethical? Are they good treatments? And is it cost effective? Those are the three major concerns that come to mind. So is it ethical? When we're talking about something being ethical, we look at 4 different things: autonomy, beneficence, non-maleficence, and justice. Is there autonomy in this? Absolutely. We make an informed decision with our patient. The patient makes a decision. Are we doing good for our patient? Absolutely. You're saving their life. You're improving their quality of life. Non-maleficence, we're not doing any harm. We're just adding one extra pill to keep their hepatitis B at bay. And justice, benefit for the society at large. Their family, caregivers, other patients will all benefit. So can we ask the question is it ethical not to transplant Hep B positive organs? That might be a better question. The second thing that might be a concern is like, are there good treatments? Are there any good cures? We have very good treatments. We have been using them for years. Tenofovir and entecavir are the one that everyone has been using for decades. Many new drugs in the pipeline, close to 500 active randomized controlled trials, and functional cure.
Thank you. And now Dr. Haley Vora from Mayo Clinic, Jacksonville, will provide the composition.
Good evening, everyone. My name is Haley Vora, and tonight I'm going to talk to you about hepatitis B surface antigen positive donors and why it's just not worth it. I will tell you that there's not enough data, that there are potentially worse outcomes, and there's already limited hepatitis B surface antigen positive donor use. So it's not going to shorten our patients' waiting time on the waiting list. And with unknown donor history, as is typically provided, there's an unknown risk of hepatocellular carcinoma. So as it stands, there are very few current hepatitis B surface antigen donors in the United States. There were 2 large post hoc analyses of UNOS liver transplant data over a period of 20 years. And in those, only 2 out of 1,000 donors were hepatitis B surface antigen positive. And the outcomes for these studies were reported based on donor status, not recipient status. Again, data is very limited on hepatitis B surface antigen negative recipients of positive donors. A recent meta-analysis, showed a total of 8 studies only, 5 of which were case reports, and 3 of which did not compare outcomes based on recipient hepatitis B status. So what we know is our patient is guaranteed to acquire hepatitis B infection with active viral replication, as he is hepatitis B naive. With that will come with viral suppression, which will be essential. There's no consensus on regimen for recipients of hepatitis B surface antigen donors, but we know it's most likely lifelong. In immunocompetent patients, only 5 to 10% achieve hepatitis B surface antigen to hepatitis B surface antibody seroconversion after 10 years. So this will be much likely lower in immunosuppressed patients, not to mention the substantial cost and psychosocial impact on the patient. And with reactivation, there can be life-threatening outcomes. including severe allograft hepatitis, fibrosing cholestatic hepatitis B, graft dysfunction, and death. So with the de novo hepatitis B infection, as our patient will acquire, there will be more lifelong medications. And these come with side effects, including renal insufficiency, osteoporosis, lactic acidosis. And there's a potential for reactivation or breakthrough if there is non-compliance, which there is in a certain percentage of people. So like we were talking about, there is very limited data, and the data we do have that has a larger cohort comes from China. They looked at patients from 2007 to 2012 that were hepatitis B surface antigen donors versus hepatitis B surface antigen negative donors. And they found that despite being on antiviral medications, there's an increased recurrence of hepatitis B in recipients of hepatitis B surface antigen positive donors. And there's decreased survival in hepatitis B in recipients of hepatitis B surface antigen donors. So like I said, there's already very limited hepatitis B surface antigen positive donor use. In the past 6 years, only 0.4% of all liver transplants were from hepatitis B surface antigen or NAT positive donors. There are up to 10,000 other extended criteria donors listed here that are available for our patient. And so with a hepatitis B surface antigen donor, even then, donor characteristics are typically not known. Therefore, the risk of HCC is not known. For all patients, despite status of their liver, hepatitis B surface antigen positive patients have a lifetime risk as high as 15 to 40%. And what we know is de novo hepatitis or HCC is highly associated with recurrence of viral hepatitis. So since the risk of HCC depends on donor characteristics, which are not always available, we don't know the long-term risk of HCC, and there are no guidelines on surveillance after liver transplant, which can come with cost, stress, and psychosocial impact on our patient and their family. So in conclusion, we know our patient will get hepatitis B and they will be on lifelong treatment for it. His risk for HCC is unquantifiable. And at baseline, there's very limited hepatitis B surface antigen positive donor use. So that not only does that make the data limited, but it's not going to extend his wait time. And there are many other alternative extended criteria donors with well-known post-transplant data that can give this patient a higher chance at liver transplantation. Thank you.
And now Dr. Ismael for the rebuttal.
Thank you. I would like to thank my colleagues first for their presentation and valid points on both sides. I would like to emphasize why we argue that he, in fact, should get this, our patient should get this Hep B liver. In regards to the point that you're mentioning that there's not enough data, since that study by Lodge et al., there's actually been more studies, especially one by Lee et al. In 2018, that even looked at more Hep B donor positive livers that were transplanted to Hep B donor to Hep B recipient negatives. And even those showed good survival and compared to the patients who were receiving Hep B DNA negative livers. In addition, I would refer to the study that you're mentioning by Wei et al., the Chinese study that looked at a larger population. Even though they did see more evidence of Hep B in our patients, however, they did show that there is similar survival in both groups. If we want to look more at, you're mentioning that our patient should decline this high-risk donor and wait for other possible livers. Well, in the study by Chrome et al., where they were looking at the risk of declining high-risk livers, our patient would get about 30% chance of getting another liver in the next year, and would have, in our specific MELD group of 15 and higher, he would have about a hazard ratio of mortality about 2.34%. So yes, even though there are other livers out there that he could potentially get, he may not afford to wait that long for those livers. And I would like to go back and talk about the third problem that you're mentioning, and the risk of Hep C. It's true, hepatitis B can increase your risk of HCC. But that being said, our patient who's going to be fresh out of transplant on appropriate antiviral therapy, there's very low chance of developing HCC. If we calculate his risk based on the studies that based on the studies with the REACH B score, his score is 7, and that would put at his risk of 3 years survival, HCC risk of 3 years of 0.2% and 10-year risk of HCC 1.2%. So overall, very low chance of getting that. Saying all that with the point that if he does not get this liver, he has a bad quality of life. We know chronic liver disease with decompensation. He's going to be being admitted multiple times for his ascites, for his complications and hepatic encephalopathy, as well as risking the chance of losing his life. Thank you very much.
And now, Dr. Pedro Palacios Argueta from the Mayo Clinic in Jacksonville will rebut the University of Florida Gainsville position.
Hi, good evening, everyone. I'm Pedro Palacios, like Dr. Rash mentioned. I will tell you why, again, it's not worth the risk to transplant a hepatitis surface antigen positive liver to our patient. They did mention about the risk of HCC, but we don't, the risk of HCC also depend on the donor status. In this case, we don't know what's the time that the patient got infected and if there's any significant fibrosis on the liver graft. Again, to mention, there's 100% risk of transmission of the hepatitis B, and it will need treatment, lifelong treatment, which goes again with side effects, costs, and we don't know about compliance, even though everyone does a good job in screening these patients for compliance, there's always a risk. And there are case reports where there has been breakthrough transmission and reactivation despite appropriate treatment. Another point that was not mentioned was what about the risk of hepatitis delta co-infection? We have to mention that this is not universally tested, and if the graft comes with hepatitis delta co-infection, this can lead to rapid liver decompensation and the need of retransplantation. Again, mentioning the risk of hepatocellular carcinoma. This risk is unmeasurable. We don't know. There's no long-term data. And like we said again, no, it depends on other donor factors. And we have long-term data. We have studies showing good outcomes on extended donor criteria, such as DCD, older donors, and fatty liver grafts. Again, to mention, this will probably not shorten the wait time of our patient on the wait list. Only 0.4% of liver transplants were hepatitis B surface antibody positive. And the Southeast specifically is a low endemic region of these types of donors. So most likely this patient will not be transplanted faster. And we also have to think about potential complications. Do we have a safety net? What if this patient develops HCC? What if this patient develops fulminant hepatitis and now needs a retransplant? All those points were not mentioned, and it's something that we need to think about when transplanting this type of patients. So in conclusion, and I think we need to think about this, what if it's our family member that is going to get transplanted? Would we recommend this type of donor? Personally, I would not. I think I would mention about and propose different extended donor criteria that has been better studied and that there's long-term outcome data.
Now we will have a 5-minute question and answer period as we welcome everyone back to the screen. Welcome to our debate number 1 judges, Dr. Chakraborty, Dr. Kotesh, and Dr. Malespin, and both competing teams. Who would like to ask the first question?
I can start. There are no takers. I have a question for the Mayo team. So you showed data from China about the increased risk of reactivation of hepatitis B. China treatment for hepatitis B in China is mostly based on lamivudine, and the data is captured over the years that is heavily weighted on LAM, and it's not really weighted on the new anti-hepatitis B treatments. It's, to my knowledge, it's retrospective, it's not prospective. And therefore, compliance of patients is not really known. So that's one aspect. So there's a lot of, so how do you respond to that in a patient that is known to be compliant? And the other thing, in terms of the hepatitis, the HCC, the risk is really commensurate to hepatitis B DNA. So the higher the DNA, the higher the fibrosis, the more the risk of HCC. So what would you tell the patient that basically can potentially get sarcopenic and therefore get more and more deconditioned? We know these patients get, infected and further decompensated. So how do you reconcile your decision if the patient tells you that you would be letting go on a liver that could come to me because everybody else is declining?
I can answer that. So in regards to the China data, yes, there are newer, higher potency antiretrovirals that are now used. But despite the therapy that was available at that time, there was still increased risk. So, I would be interested to see if that would be any different with the antivirals that we have now. Regarding the risk of HCC, like you said, it's dependent on the quantification of hepatitis B DNA, which we don't always know in the graph that is handed to us. So we, in fact, it could be quite high and make the risk of HCC even higher. And I think the biggest point I want to make is that the current donor pool for hepatitis B surface antigen positive livers is minuscule compared to other extended criteria. So I don't believe that he would be giving up an opportunity because he will unlikely even be given that opportunity.
There's also, we can all say that there's 700 more times the possibility that he gets a liver if we extend the donor criteria such as DCD. So giving up that or telling the patient to potentially not get the hepatitis B surface antigen positive liver would not put him at risk of not getting another liver. And we don't know, there's no long-term data with the new antivirals. The data we have is with lamivudine. So that's where we're going with the data we have, clear-cut data from China. Even though there is the characteristics of our patients are different, but that's what we have, and that's the only thing objective we can tell to our patient.
I guess I'd like to have a follow-up question for the University of Florida team. So first of all, great presentation from everyone and great rebuttal. So in practice, we see a lot of patients with low MELD, with portal hypertension who suffer from their liver disease and are unfortunately in bad situations. Are there any, for patients who are considering, high risk Hep B surface antigen donors, are there any specific donor characteristics that you guys came across that perhaps would be ideal for recipients who would entertain these offers?
I can answer that question. So like any other donor, they're like in a certain criteria you want to look at, like you can do it like stat biopsy and see that like how much fibrosis is there, like, stage the fibrosis. If it's advanced fibrosis, and that would not be a very good donor. If it's co-infected with hepatitis delta, that would not be a really good donor. If there's like any signs of a small HCC, that would not be a good donor. Cold ischemia time, and those are, again, prolonged cold ischemia time will not actually be very high risk in this patient population. So I think there may be like one or two things that are specific to this patient population, specifically the fibrosis stage and co-infection with hepatitis delta, that would make it probably like an unacceptable risk for a fresh post-transplant. Otherwise, they're very comparable to any other organs that are being considered by organ procurement teams around the country. I don't think there's like much of a difference.
Adding to that point, one actual benefit is we're seeing more of these Hep B donors in younger populations. So you can assure your patient that you're giving them a younger, healthier liver as opposed to the older age patients who actually have a higher risk of having NASH in their liver.
Okay, I think that's about all the time that we have for questions and answers. Before we conclude debate number 1, we will send a quick follow-up poll to the audience. Based on the presentations, have you changed your opinion on whether or not this patient should be listed for a HBV DNA or hepatitis B surface antigen positive donors? So poll number 1, 88% of the respondents marked yes, and 12% of the audience thought no. The patient should not receive a hepatitis B surface antigen or DNA positive donor. Kathy, maybe have poll number 2 now. Oh, wow. Okay. Looks like the numbers have flipped. We've gone from 88% yes to 20% yes, and 80% now feel that the patient should not receive a hepatitis B viral DNA or hepatitis B surface antigen positive donor. Well, thank you. And now we will move to debate number 2. Dr. Zori?
Yeah, I think actually we show you that only 20% changed their mind. But we'll make that a little more clear on the next polls. Before we move on to our second debate, though, I want to remind our viewers of the importance of supporting the American Liver Foundation and sustaining the vital work the ALF does for liver patients across the country. To donate, simply click on the link in the Q&A box. And now we're ready for debate number 2. Debate number 2 will be judged by Dr. Joe Morelli from the University of Florida in Gainesville, Dr. Tushar Patel from the Mayo Clinic in Jacksonville, Dr. Andrew Kiani, also from the Mayo Clinic in Jacksonville. Just as a reminder, each team is allotted precisely 6 minutes to present their argument and 3 minutes for rebuttal comments. And following the debate, a 5-minute question and answer session. Remember, when your time expires, the audio and video link will be cut off. Debate number 2 is a 7-year-old man with alcoholic cirrhosis and portal hypertension with a MELD score of 15, non-bleeding grade 1 esophageal varices, but without ascites, develops an obstructing sigmoid colon adenocarcinoma. He should undergo transjugular intrahepatic portosystemic shunt, or TIPS, prior to undergoing colectomy. University of Florida, Jacksonville will present the pro argument. University of Miami will present the con argument. It's my pleasure to introduce our debate teams. Presenting the argument that the patient should undergo a TIPS prior to undergoing colectomy is the University of Florida in Jacksonville. The University of Florida in Jacksonville is being mentored by Dr. Neha Agrawal and Dr. Peter Ghali. The debate teams are Gregory, Churchill, and Sonal, Jadeja. Presenting the argument that the patient should not have a TIPS prior to undergoing colectomy is the University of Miami. The University of Miami mentor team is Dr. Eric Martin, and the debate team mentors are Jordan Goldstein and Mahfouz. Before we hear from our debate teams, I'd like the audience to answer a quick poll based on the criteria I just read. In your opinion, should the patient undergo TIPS prior to undergoing colectomy? And I'll give everybody about 20 to 30 seconds to respond. This time around, we'll present both the answers at the end of the poll, or at the end of the debate. All right, we'll begin with the University of Florida, Jacksonville. Dr. Churchill will present the pro position. Timekeepers, are you ready? Let's begin.
Perfect, thank you. I'm Greg Churchill with University of Florida at Jacksonville. We'll be doing the benefit of preoperative tips. So it's been established that post-operative mortality in cirrhosis is disproportionately high. We cite two early studies in the 2000s, 140 cirrhotic patients undergoing abdominal surgery at a mortality rate of 23.9% within 30 days. In a separate study, 825 cirrhotic patients undergoing surgery, 562 of these intra-abdominal non-coles, had a mortality rate of 25.4% within 30 days. And this is specific to a MELD of 12 to 15, which is exactly where our patient is. There's a 1 in 4 chance that our patient will die within 30 days. What's the physiology of cirrhosis and surgery? General anesthesia places significant stress on the human body, even more so in the setting of cirrhosis of someone with little reserve. Hypoxia, hypovolemia sparks a physiologic cascade of autoregulation, AV shunting, decreased splanchnic flow, and vasodilatation. All of this leads to the risk of further hepatic decompensation. The above can exacerbate portal hypertension, which our patient already has with grade 1 varices, which can lead to significant postoperative morbidity, including ascites, poor wound healing, infection, bleeding, all of this directly related to mortality. It's shown that portal hypertension increases surgical mortality. 2 studies have utilized a nationwide database that takes 20% of hospitals in the US, all of their discharge data. They compare cirrhosis compensated versus cirrhosis complicated by portal hypertension. Cirrhotic patients have an 8-fold increase in death, but if you see with the patients with portal hypertension as well, there's a 22.7-fold increase in death, markedly higher. Specifically, they also looked at colectomy as a subgroup. They showed that there was a mortality for cirrhosis in 6% versus those with portal hypertension at 17%. A similar study also concludes an in-hospital colectomy mortality rate of 14% in cirrhosis and 29% in cirrhosis with portal hypertension. If you're able to see the chart on the right-hand side here, the blue represents non-cirrhosis, red cirrhosis, green portal hypertension. This specifically shows the top one. There's an increased length of stay. Next one shows an increased length of cost, increase in cost. And finally, you can see there is a marked difference in the colectomy group between cirrhosis versus cirrhosis with portal hypertension, a much higher mortality rate. TIPS can decrease mortality and it's safe at a MELD of 15. To date, there have been no prospective studies evaluating the safety and efficacy of preoperative TIPS, so it can't be routinely recommended. And given the higher risk of mortality in patients with portal hypertension, it was just, as we just showed, the TIPS can actually decrease postoperative morbidity and mortality. So what's the safety of TIPS? The greatest mortality is with greater than 24. The mortality risk is more significant with a MELD greater than 15 or an age greater than 70. Our patient has a MELD of 15 and is 70 years old. MELDs of 15 or less correlate with an event rate of 10% versus 22% when greater than 15. And a MELD of 18 or more have a significantly lower 3-month survival than patients with a MELD of less than 17. Clearly, our patient fits with this 15 and below category here. What does the literature show in regards to this? It's all retrospective at this time. There's no prospective trials. 7 original studies of 24 patients undergoing preoperative TIPS for portal hypertension prior to abdominal surgery. They reported no postoperative mortality or major bleeding. Death due to liver failure occurred at 5 weeks in a CPS Class C patient, a patient at high risk already, as we showed in our first slide. Another study showed 19 patients undergoing preoperative TIPS at a single center prior to abdominal surgery. 1 patient died 78 days after the surgery, but to note, this patient had a Mayo 30-day mortality risk of 41%, much higher than our patient at its baseline. 19 studies of 64 patients undergoing preoperative TIPS prior to non-hepatic intra-abdominal surgery showed no mortality related to TIPS. 3 of them developed encephalopathy, which were reportedly treated successfully with medical management. This is extremely important because we all know that TIPS can cause hepatic encephalopathy. And clearly, this shows that it's very manageable in this patient population. There's no increase in overall morbidity or mortality related to these 64 patients. So in conclusion, despite there being no prospective trials for TIPS, it should be considered in patients with portal hypertension prior to abdominal surgery, given there is such a high risk of mortality. The retrospective studies show its favorable outcomes, especially at a MELD of 15 for our patient. We believe for our patient, the benefit clearly outweighs the risks of TIPS placement to decompress the portal system, decrease the risk of further hepatic decompensation, ascites, wound healing, bleeding, infection, and ultimately decrease the risk of death.
And now we'll hear from our opposing team from the University of Miami. Dr. Mahfouz from the University of Miami will now present the con position.
All right, good evening, everyone. As we all know that portal hypertension leads to venous congestion that leads to peri and post-operative complications that including ascites, variceal hemorrhage, and increased mortality. The strategy of using preemptive TIPS as neoadjuvant procedure to decompress the portal vein and reducing complication has been suggested. But the question, is it really effective, especially for our patient? I'll be spending the next 6 minutes of your time convincing you why our patient should not get TIPS prior to his surgery. First, let's talk about the available level of evidence to support preemptive TIPS. The strongest level of evidence is usually achieved by randomized controlled trials or systemic review of randomized controlled trials. As we see in this table, which was adopted from a large systemic review study by Lahat and looked at the outcomes of non-hepatic surgery in cirrhotic patients with portal hypertension prepared by TIPS. The vast majority of these studies were case reports and small case series describing the role of preemptive TIPS. I selected a study that included patients who underwent surgeries for colon cancer. Until today, there is only 2 retrospective case control studies. One was done by Vinay in 2006, and the largest one was done by Tapshuri in 2019. Interestingly, these 2 studies excluded patients older than 70 years of age, and some patients included in this study who received TIPS, they had pre-existing bleeding or ascites. Until today, there is no prospective studies or randomized controlled trials. Now, let's see what the largest 2 studies showed. The first case control study is by Vinet in 2006, included 35 cirrhotic patients. 18 of them underwent TIPS before surgery, and 17 went directly to surgery. 10 of them underwent colectomy. Both groups had similar rates of operative blood loss, post-operative complications, and duration of hospitalization. No significant difference were observed for 1 month and 1 year cumulative survival rates. Finally, it's important to mention that surgery was delayed with a mean of 72 days in patients who received TIPS prior to surgery. The largest study till to date was conducted by Tapshuri in 2019. This study included 134 patients from 4 centers in France. 66 of these patients underwent TIPS before surgery, and 68 were used as a control group. This table represents the colorectal surgery subgroup, which represents 54% of the total patients. Even though TIPS group of patients required less intraoperative blood transfusions, they had similar rates of post-operative complications to the control group. They also had similar 90 days mortality rates. With all the advances in TIPS procedure and its techniques, it's still not without complications. Besides the risk of bleeding, stent malposition, hepatic encephalopathy, and even death for this preemptive procedure, older age itself was associated with increased mortality after TIPS based on recent study published in 2020. Therefore, TIPS should be pursued cautiously in this age group with a very clear indication before proceeding. We don't know the ideal waiting time for TIPS to work before proceeding with surgery. Based on available studies, surgery was delayed for weeks to several months. Vinay's study reported a mean delay of 72 days, for example. As we know, delaying urgent surgeries comes with consequences. Our patient has an obstructive mass in his colon, and delaying his surgery will place him at risk for perforation and even death. Tapshuri also reported that patients who underwent surgery less than 40 days following TIPS presented with more severe liver disease. And the author suggested that given no differences were found in terms of survival and the outcomes, postponing surgery for more than 40 days following TIPS placement might be beneficial. In conclusion, TIPS is safe with only 1.2% procedure-related mortality. The age of our patient placed him at higher risk of mortality for preemptive procedure. Preemptive TIPS would cause a delay in urgent surgery, although the portosystemic gradient immediately reduced after TIPS placement, which lowered the risk of intraoperative bleeding, but the control of ascites, which is largely dependent on the natriuresis, is delayed up to 4 weeks after TIPS, and the optimal delay remains to be defined. Finally, the use of preemptive TIPS is not supported by a strong level of evidence, with no prospective trials until the moment, with only 2 case control retrospective studies and some case reports. Going back to our patient, if I want to consent him for preemptive TIPS, I would tell him that if we proceed with TIPS prior to your surgery, you will require less blood transfusions in the OR. However, we will need to delay your urgent surgery for TIPS to work, and let's hope that you won't develop any complications for that. Given your age, you have higher chances of becoming confused from TIPS, and you have higher mortality rates. The alternative to that, you can go immediately to your surgery to remove the obstructing mass, and we can manage any potential complications from elevated portal pressure medically or endoscopically if they occur. Finally, I want to say I cannot recommend TIPS to our patient with such a low level of evidence to support it. Just because we can do it doesn't mean we should. And thank you very much.
Thank you. And now for the rebuttals. Dr. Jadeja from the University of Florida, Jacksonville will rebut University of Miami's position.
Good evening. So it has been pointed out by the opposing team that there is currently a lack of evidence to support routine preoperative TIPS. If we had clear evidence in favor of routine preoperative TIPS, we would not be having this debate today. So what we really need to focus on is what we do know. And what we know is that there's a significant increase in mortality, length of stay, and cost in patients with cirrhosis and clinically significant portal hypertension undergoing abdominal surgery, such as our patient. And the opposing team argues that because he presented with an obstructing sigmoid adenocarcinoma, this is an urgent surgery and we should go straight to surgery. And I argue that because he presented with an obstruction, the optimization of his clinical status prior to surgery is of the utmost importance. And this is because patients with obstructing sigmoid colon adenocarcinoma have even a higher morbidity and mortality with operative surgery than those who do not present with obstruction. They also have a higher recurrence rate after curative surgery and may not even be candidates for curative surgery. They also likely require adjuvant chemotherapy. And so by setting him up and optimizing him with the preoperative TIPS, we're not only helping his postoperative success, but potentially his long-term adjuvant chemotherapy and need for further treatment options. TIPS has been proven to be safe in carefully selected patients, with a large comparative study in France showing a lower incidence of post-op ascites in the TIPS group with no difference, like we mentioned before, in severe complications or 90-day mortality, and that it's well tolerated in patients with a MELD of 15 or less. TIPS has also been shown to have a positive impact on systemic hemodynamics that we cannot ignore. A study in 2018 by Garcia and colleagues showed that by displacing blood from the non-central regions into the central vasculature compartment led to an increase in central blood volume with improved ionotropic effect on the heart without significant diastolic dysfunction and improvement in renal blood flow and function. There is also a decrease in bleeding post-TIPS and improvement in overall body composition with an increase in muscle mass. This survival advantage with an increase in muscle mass has been shown to independently lower patient mortality. And again, an overall minimal delay to surgery in most retrospective studies of about 4 to 6 weeks. And in most cirrhotic patients, they require optimization prior to surgery. Finally, TIPS has been widely used in the clinical settings since the 1990s, with studies in the past 20 years redefining the role of TIPS. When we look at preemptive TIPS and variceal bleeding, 5 randomized controlled trials showed a decreased mortality and risk of rebleeding in a specific subset of high-risk patients. And to this day, it's still being underutilized. Only 16 to 13% of eligible patients undergo preemptive TIPS, even though the number needed to treat is 4. Compare this to our cardiology colleagues who use PCI and MI daily in their practice with a number needed to treat of 31. This tells us that we need to be more aggressive and innovative when we look at the potential role of TIPS in the management of our cirrhotic patients.
And now Dr. Goldstein from the University of Miami will rebut the University of Florida, Jacksonville's position.
Good evening, everyone. Thank you for the great presentations. Just to emphasize, while theoretically there could be some benefit in reducing portal pressures and decreasing the risk of ascites and bleeding, the current literature does not support preoperative TIPS. Given the complex pathophysiology associated with cirrhosis, it is important to follow evidence-based medicine. We are in agreement that people should be optimized prior to their surgeries. However, TIPS is not necessarily the way to do it. And I agree that currently there are only retrospective studies to date. And because of that, the AG guidelines on surgical risk assessment and perioperative management of cirrhosis in 2019 does not routinely recommend TIPS prior to surgical procedures. The team also brought up an article by Lahat from 2018, and that was basically the major trial showing that there is a benefit of TIPS prior to surgery. However, if you look closer at Lahat's study, there's only 64 patients, and only one of the studies actually had a control group, and that control group was by Vinet, and his study, if you look at that one, did not show any benefit to preoperative TIPS. Additionally, while one of the theoretical benefits is to decrease ascites perioperatively, 60% of the patients from that study still had ascites before their surgery. Additionally, it takes around 4 weeks to see the full natriuretic effects of TIPS. And while 2 of the 64 patients had semi-urgent surgeries and didn't get to see those effects, the remainder were elective surgeries, waiting up to approximately 5 months between TIPS and surgery. And unfortunately, our patient doesn't have that luxury, given that he has an urgent surgery in the setting of a colonic obstruction. Additionally, the team mentioned that it's a low-risk procedure. Yes, TIPS is overall a very low-risk procedure, but it does have inherent risk to the procedure itself, as well as to our patient. Given his advanced age of 70, as well as his MELD, he is at increased risk for hepatic encephalopathy, cardiac decompensation, as well as acute liver failure. There are multiple studies which show an increased rate of mortality and hepatic encephalopathy as the age and/or MELD score increase. So why put an older gentleman pending an urgent surgery at risk by putting him through a procedure which is not supported by current evidence? Additionally, the team mentioned that there's a lower risk of bleeding associated with TIPS procedure. While the French study with Churchill does show less PRBC transfusions, only 50% of the hospitals reported data, so it's incomplete, and the Vignette study did not show any change in the amount of red blood cells needed to transfuse. Additionally, more importantly, there was no difference in mortality in either study. They also mentioned that you can treat hepatic encephalopathy preoperatively. The most recent study by Bureau from 2021, which was a randomized controlled trial, did show benefit. However, they started rifaximin 2 weeks prior to getting the procedure, which our patients did not have that benefit. So currently, unfortunately, I do not believe that the current studies support pre-surgical TIPS, and I would not feel confident consenting the patient for this procedure.
Thank you to our debate teams who did a great job. And now let's take some questions from the debate number 2 judges panel. Welcome to our debate number 2 judges, Dr. Morelli, Dr. Patel, Dr. Kiani, and both competing teams. From the judges, who would like to ask the first question?
I'll go ahead and start. So, great presentation by both teams. I have a question for the UF Jacksonville team. So should we consider doing a TIPS prior to abdominal surgery in every patient with cirrhosis and portal hypertension that has MELD of 15 or higher?
So I think that, just like when we're looking at preemptive TIPS or variceal bleeding, we need to identify a select group of patients that will benefit from this. And we do this with prospective studies to see. I do think that this patient would be a good candidate, given that his MELD is 15. Based off of we don't know all of his blood work, but if he's child Pug A or child Pug B, it would be well tolerated. And he has an appropriate high risk with his obstructing sigmoid adenocarcinoma that makes the potential benefit of a preoperative TIPS worth any potential risk. Do I think every patient should go just because they have portal hypertension and they're going under surgery? No, not necessarily. We need to identify patients in the right clinical setting and someone who's going to need adjuvant therapy, potentially long-term, and nutritional status needs to be optimized. I think these are the patients who would benefit the most.
Thank you.
Dr. Kiani or Dr. Morelli, do you guys have a question?
I have a question for the con group. They spoke about the VNA study, and since the cirrhotic population so heterogeneous, you may mention this. What were the CTP scores for those patients, or the MEL scores? It was done in 2006.
Okay, I'll answer this question. So the CP, so sorry about that. The MEL score was significantly lower compared to our patient, patient, the one we presented. If I remember correctly, it was about like 6 to 8, or in some of them was like 8 even to 12. It was a very heterogeneous, sample, and it wasn't really reflecting our patient. As I mentioned, also they excluded the patients who are above the age of 70, and the mean age group was about like 58 to 62 or 63 as well. About their CBT score, it was I believe they have like A and B, and they excluded CBT score of C as well.
Very great presentation. I apologize, my video is not working. I have one question for the UF Health team. If you knew what the hepatic venous portal gradient was, pressure measurement, if you could get portal pressure, would that influence your decision to put a TIPS in or not?
I'm actually not so sure, because we already know this patient has probably a gradient of at least 10 or probably greater than 12 at this point. And we know that clinically significant esophageal bleeding can happen anytime above approximately those areas. So he is probably very close to that. If it was much higher, I don't know if it would influence us any bit more.
But if it was lower, if the MEL did not reflect the HVPG?
I see. Then, I figure we probably wouldn't be seeing the evidence of portal hypertension in regards to varices or ascites at that point in time. So, we have to assume that it's above a certain threshold if he is having evidence of portal hypertension clinically.
Well, the threshold for bleeding is greater than 12, but the threshold for developing ascites is not known. So there are other factors. So if you're putting a TIPS in, as your assumption is to decrease portal hypertension to 0, in a sense, decrease any potential risk of decompensation.
Thank you to the judges and to the debaters. Before we conclude debate number 2, we'll send a quick follow-up poll to the audience based on the presentations. Have you changed your opinion on whether patients should undergo TIPS? Here's the answer to the question. In your opinion, should a patient undergo TIPS prior to undergoing colectomy? This is the pre-poll. So 36% said yes, while 64% said no. Did these presentations change your opinion on whether or not this patient should undergo TIPS prior to colectomy? And 24% changed their mind based on the debate. Sorry, we're not able to give you guys an answer to which way they changed their mind at this point.
Well, this evening is getting better and better. We're now ready for debate number 3. As a reminder, each team will be given 6 minutes to present their argument and 3 minutes for rebuttal comments. And following the debate, we will have a 5-minute question and answer session with the judging panel. The judging panel for debate number 3 will be Dr. Joydeep Chakraborty from the University of Mississippi, Dr. Kotesh from Advent Health, and Dr. Malespin from Tampa General. Debate number 3. A 26-year-old woman with a history of congenital heart disease status post-Fontan procedure as a child presents with failing Fontan physiology and is considered an acceptable candidate for heart transplantation. Imaging shows a nodular liver with no signs of portal hypertension. Biopsy shows stage 4 fibrosis. She should be listed for a combined heart-liver transplantation. Emory University will adopt the pro position and Duke University the con position. Presenting the position that this patient should be listed for a combined heart-liver transplantation is the team from Emory University. The team's mentor is Dr. Marget Flynn. The debate team members are Dr. Mechu Narayanan and Dr. Michael Andrew Yu. The team from Duke University will be presenting the position that this patient should not be listed for a combined heart-liver transplantation. The Duke team mentor is Dr. Lindsay King, and the debate team members are Dr. Stephanie Gabarino and Dr. Jackie Henson. Before the presentations begin, we'd like you to answer a quick poll. Based on the criteria I just read, in your opinion, should the patient be listed for a combined heart-liver transplantation? Dr. Mechu Narayanan from Emory will now present the proposition. Timekeeper ready? Let's begin.
Combined heart-liver transplantation for Fontan-associated liver disease. There are no clear prognostic markers for Fontan-associated liver disease, no clear guidelines in regard to HCC screening or for the selection of heart transplantation versus combined heart-liver transplantation. As shown above, it is not clear which patient's liver disease will stabilize versus decompensate after heart transplantation alone for failing Fontan. The mean duration of Fontan operation to a diagnosis of cirrhosis was 23.4 years. Liver biopsy remains the gold standard for assessment of liver fibrosis and diagnosis of cirrhosis. Clinical signs and symptoms of cirrhosis usually present late in Fontan-associated liver disease. Fontan patients with features of portal hypertension have a 9-fold increased risk for major adverse events. Most patients who have regression of liver disease after heart transplant alone were less than 10 years out from Fontan operation. As our patient has a failing Fontan, stage 4 fibrosis/cirrhosis, and is more than 10 years out from Fontan, we advocate for combined heart and liver transplantation. Among patients who underwent heart transplant, cirrhosis on pre-transplant imaging is associated with worse outcomes. Better outcomes can be achieved for Fontan-associated liver disease patients with cirrhosis who undergo combined heart-liver transplant. In our patient with a failing Fontan and cirrhosis, combined heart-liver transplant will lead to a better outcome. In a study by Sangha et al. In 2021, compared outcomes between patients who underwent heart transplant with and without cirrhosis, as well as combined heart and liver transplant. On the left, you see post-op complication rates were highest in patients with cirrhosis who underwent heart transplant alone. On the right, the estimated 1-year survival for patients with cirrhosis who underwent heart transplant alone was 67%, compared with 89% for patients who without cirrhosis who underwent heart transplant and 89% for patients who underwent combined heart and liver transplant. Acute cellular rejection is a common problem after cardiac transplantation and is treated in about 13% of patients during the first year after cardiac transplant. ACR can cause graft dysfunction and contributes to about 11% of death in the first 2 years after cardiac transplantation. There's an immunologic benefit to proceeding with combined heart-liver transplant with less risk of acute cellular rejection and humoral rejection episodes. In a retrospective cross-match of 45 patients at Stanford, no patients who underwent combined heart-liver transplant experienced cardiac rejection, whereas 32% of heart transplant patients had rejection. This finding has been replicated at other centers as well. I have discussed the survival advantage and immunologic benefit of performing combined heart-liver transplant for a patient with failing Fontan with cirrhosis. But despite this, some might argue to defer until patients present with decompensated cirrhosis to evaluate for liver transplantation. However, delaying liver transplant until decompensation or ACC results in poor outcomes in this patient population. Of 10 patients with a history of heart transplant for congenital heart disease with surgery who were listed for liver transplant, only 1 pediatric patient received a liver transplant. 4 out of 6 adult patients died while on the liver transplant wait list. 4 out of 6 adult patients on the liver transplant list were listed for liver transplant within 1 year of having a heart transplant. The risk of HCC is not insignificant for Fontan-associated liver disease patients with cirrhosis. The annual incidence is about 1.5 to 5% and progresses with time. The 1-year survival of Fontan-associated liver disease patients with diagnosed HCC is only about 50%. Surveillance rate for HCC are poor and guidelines are not clear on the interval or modality for screening. Ultrasound can often miss lesions and MRI is not feasible due to the presence of pacemaker or defibrillator in this patient population. Lesions that are found can be difficult to investigate due to location and anticoagulation status. Based on the available data, if our patient develops HCC after heart transplantation, her outcomes would be very poor. An AST multidisciplinary group of experts has laid out a clinical algorithm for the evaluation of patients with failing Fontan, which supports our advocacy for combined heart-liver transplant. Based on this algorithm, our patient with failing Fontan and stage 4 fibrosis, cirrhosis, on biopsy should be evaluated for combined heart-liver transplant. In summary, Fontan-associated liver disease patients with cirrhosis who undergo heart transplant alone have poorer outcomes, including a lower survival rate compared to patients without cirrhosis. Patients with Fontan-associated liver disease with cirrhosis who undergo combined heart-liver transplant have similar, if not improved, outcomes compared to patients with Fontan-associated liver disease without cirrhosis who undergo heart transplant alone. Our patient has cirrhosis without signs of portal hypertension. Waiting until she develops decompensated cirrhosis or HCC list for liver transplant puts her at risk for poorer outcomes. There is an immunologic benefit to combined heart-liver transplant. The risk of HCC is unclear long-term in patients with Fontan-associated liver disease, but not negligible. 1 year survival after diagnosis of HCC and Fontan-associated liver disease is 50%. Our patient is a 26-year-old who had Fontans at least 20 years ago and has done well so far. Her biopsies indicate cirrhosis. To not give her a combined heart-liver transplant would be a disservice to her and not provide the best chance for long-term survival. These are my references. I just wanted to thank Dr. Flynn and Dr. Ford.
Dr. Stephanie Garbarino from Duke will present the composition.
Hello, everyone. My name is Stephanie, and my co-fellow Jackie and I are presenting today under the mentorship of Dr. King from Duke University. We will be making the case that this patient should not be listed for a combined heart-liver transplantation. Let's start off by talking about this patient's liver biopsy results. We are told this patient has stage 4 fibrosis on biopsy, but what does that actually mean in terms of her liver function and outcomes? The graph on the left shows a study of 21 adult Fontan patients. As you can see by the red triangles, the degree of hepatic function was not correlated with the degree of fibrosis in FALD, whereas it was for patients with viral hepatitis shown by the black circles. The graph on the right shows a study of 68 subjects with FALD, where fibrosis grade, either 0 to 2 on the top line or 3 to 4 on the bottom line, was not predictive of either transplant-free survival or overall survival. This suggests that her biopsy results may not correlate with hepatic function or meaningful clinical outcomes. How about the degree of liver fibrosis and outcomes specifically after heart transplantation? In a series of 20 post-Fontan patients who underwent heart transplant alone, there was no effect of pre-existing cirrhosis on outcomes. Despite being older, patients with cirrhosis had a similar 1 year survival, 86 versus 77% comparatively, compared to patients without cirrhosis. Let's shift gears for a second. We're told this patient does not have evidence of portal hypertension. We must remember that compensated cirrhosis, which this patient does appear to have, is not in and of itself an indication for liver transplant. Let's delve into this a bit further. While fibrosis is not prognostic in FALD, the presence of portal hypertension actually is. In the VAST study, 73 Fontan patients were evaluated for indicators of portal hypertension, cleverly named VAST, varices, ascites, splenomegaly, and thrombocytopenia. Patients were given 1 point for each of these features. With a score of greater than or equal to 2, they were 9 times more likely to progress to death, transplant, and HCC. The fact that our patient does not have portal hypertension means her overall prognosis is much, much better, and transplant may be premature. An important aspect of this case is that not listing for liver transplantation is not just delaying the inevitable. Her liver disease is due to her Fontan physiology, hepatic congestion from high CBP, and chronic hypoxemia, both of which will be reversed by a heart transplant. A case report published in 2018 of a 24-year-old Fontan patient with cirrhosis on biopsy, which you can see on the top line here, who underwent heart transplant alone, had near complete regression of fibrosis and reversal of cirrhosis on repeat biopsy 18 months later, which you can see on the bottom. This suggests that even biopsy-proven cirrhosis can reverse with heart transplant alone in these patients. Here we present actual data comparing outcomes between FALD with combined transplant versus heart transplant alone. This recent single-center retrospective study included 47 patients and found similar mortality after a median follow-up of 17 months. Of the patients who received a heart transplant, nearly 30% had cirrhosis, and at least 2/3 of those had portal hypertension. These patients were evaluated by teams who deemed them suitable for either heart transplant alone or a combined transplant, and both groups included patients with cirrhosis, and despite that, their outcomes were similar. At the crux of this debate is whether a liver transplant in this situation is an appropriate use of a scarce resource. In 2019, more than 1,200 people died waiting for the liver transplant. In addition, there are real consequences for listing a patient for a dual organ transplant, including limiting potential donors and thus prolonging wait time, increased technical surgical complexity, ischemic time, and other surgical risks. Finally, there's no actual system in place for deciding when an FALD patient needs a dual organ transplant. And thus, we as providers need to be extra thoughtful when making these decisions to not introduce our own biases. Some may argue there's a potential persistent risk for HCC after our heart transplant. However, there's no actual evidence to support this, and a cumulative rate of HCC in a Fontan patient after 10 and 20 years pre-heart transplant are very low. In addition, the published annual incidence rates are about 1%, and that is not higher, and in some cases actually lower than other liver diseases. And the bottom line is all chronic liver diseases have a risk for HCC, and we do not transplant preemptively in these patients. In conclusion, we do not feel that this patient warrants liver transplant listing. We have provided evidence that cirrhosis on biopsy, specifically in Fontan patients, may not be indicative of degree of fibrosis or hepatic function, nor predictive of outcomes, including post-transplant survival. In this case in particular, she appears to have very well-compensated cirrhosis without evidence of portal hypertension, which is predictive of liver-related Fontan outcomes, and thus should have adequate hepatic reserve to undergo a heart transplant. We have also presented evidence that these patients can experience regression in fibrosis and cirrhosis with heart transplant, and not performing a liver transplant right now is not simply delaying an inevitable progression of disease. Based off the information provided, we would not list this patient for liver transplant, and instead, this case should be reviewed by a multidisciplinary collaborative committee with additional data besides the presence of cirrhosis alone to help adjudicate whether a scarce resource should be used. Thank you.
Now, Dr. Michael Andrew Yu from Emory will rebut Duke's position.
Thank you very much, Duke team, for your opposing arguments and an argument against offering this 28-year-old female a combined heart-liver transplant, specifically talking about fibrosis, regression, biopsies, and resources. Per the OPTN, ethical decision-making for combined organ transplant should take into account both utility and equity. In our patient, a combined heart-liver transplant maximizes utility, as shown by Cotter et al. And Rucker et al. Receiving the combined heart-liver transplant is associated with equal, if not lower, mortality, and allows the patient to reap the maximum benefits. These benefits include: 1, a reduced incidence of rejection, especially if 20% of patients with congenital heart already have allosensitization and thus a smaller donor pool. And 2, eliminating the risk of HCC, for which the annual incidence of Fontan-associated liver disease is up to 5%, and once diagnosed, presents an abysmal 50% chance of survival, as demonstrated by Posner et al. And replicated in a large Japanese study by Sagawa et al. A sequential liver transplant can be a viable alternative, but you lose the rejection benefit, and you do have a 6-fold higher chance of acute rejection in 1 year. From an equity standpoint, as demonstrated by Goldberg et al., the effect of simultaneous heart-liver transplant on the liver does not have a great effect on the standard liver transplant wait list, for median of 87 days compared to baseline 24 days. And patients bypassed by candidates for simultaneous heart-liver did not have a higher mortality. With respect to histology and biopsies, 2 studies, one at Stanford and one at UPenn, demonstrated that explanted livers actually showed greater fibrosis in about 30 to 40% of cases compared to pre-transplant liver biopsy. Next, while you mentioned that one case study showing regression of fibrosis, most cases where there is regression of fibrosis are in patients who are adolescents. And in cirrhosis, it is very little. It would be hard to trust just one case study for your argument. In summary, a combined heart-liver transplant in our patient would provide her with the best long-term survival benefit with reduced organ rejection, as well as an eliminated risk of HCC, while having an overall minimal effect on the liver transplant wait list. Next, pre-transplant biopsies are often underestimating the level of fibrosis, and the evidence supporting regression of cirrhosis following heart transplant alone is in a failing Fontan is limited this far out. Waiting until she develops signs of portal hypertension to list her would not be advocating for her livelihood, and rather would be a disservice. Thank you for your time.
And now Dr. Jackie Henson from Duke will rebut Emory's position.
Thank you. We would like to make several points in response to Emory's argument. First, we would like to again emphasize that from what we are told of this patient, she has stage 4 fibrosis on a single liver biopsy, but importantly does not have any evidence of portal hypertension. Studies in patients with Montana-associated liver disease have demonstrated that degree of fibrosis in and of itself is neither indicative of liver function nor prognostic of outcomes, as we have highlighted. Portal hypertension, on the other hand, appears to be a more important factor affecting outcomes, and she does not have this. With regards to the study, our opponents highlighted to suggest inferior outcomes after heart transplant with cirrhosis, we would like to make several points. First, none of these patients are reported to have experienced morbidity or mortality related to hepatic decompensation, making it difficult to implicate liver disease as the culprit behind any differences in outcomes. The reported postoperative complications highlighted included reintubation, neurologic events, and mechanical circulatory support, and the unplanned surgical events similarly included procedures such as chest washout, craniotomy, colonoscopy, and tracheostomy. In addition, the cited causes of death included ventricular fibrillation and intracranial hemorrhage. In addition, the difference in survival was not statistically significant, and it was an unadjusted analysis. We would need analyses taking into account important confounders to draw the conclusion that cirrhosis was driving these differences. We would also ideally base such a conclusion on biopsy data, which our opponents themselves highlighted as the gold standard. These patients' diagnosis of cirrhosis was based on imaging, and there was some discordance with the limited biopsy data available. In addition, nearly all with cirrhosis had manifestations of portal hypertension, making them different from our patient and therefore difficult to draw a direct parallel. Next, with regards to the risk of HCC, as we discussed earlier, we do not preemptively transplant patients due to a risk of future HCC. This is an unfortunate complication of chronic liver disease for which we serially screen patients at risk. As we discussed earlier, the annual incidence rate in recent case series was around 1% for patients with Montana-associated liver disease, which is similar to or even less than some reported estimates for other etiologies of liver disease. We would suggest ongoing HCC screening in this patient post-transplant. In the event that HCC develops or her liver disease progresses and she develops decompensated cirrhosis, she could then undergo a liver transplant, which would now be with a functioning heart and therefore a lower risk from that perspective. In addition, the argument has been made that the patient should be listed for combined transplant as this may provide an immunologic benefit over heart transplant alone. If true, this would be a nice benefit to those for whom a combined transplant is otherwise indicated. But a decreased risk of acute rejection alone is not an indication for liver transplant. Many individuals across the world undergo heart transplant every day and do not require a concomitant liver transplant to prevent rejection. To close, we would like to again emphasize that at the center of this debate lies whether a liver transplant in this situation is an appropriate use of a scarce resource for which we must be thoughtful stewards. We feel that given the information provided, this patient has very well compensated cirrhosis without evidence of portal hypertension and thus should have adequate hepatic reserve to undergo a heart transplant. And there is no indication for a liver transplant at this time. Thank you.
Congratulations to both teams for such a great debate. And now we will invite our judges to join us for a 5-minute question and answer period. Welcome to our debate number 3 judges, Dr. Chakraborty, Dr. Cortege, and Dr. Malespin, and both the competing teams from Emory and Duke. Who would like to ask the first question?
I can go. So great presentation for both the teams, and I have 2 questions for the Emory team. First question being, would knowing the MELD or the MELD XI score for this patient that we have in the vignette change your decision of combined heart liver versus just a heart transplant if it was a low MELD or MELD XI score?
I can answer that question. I actually would not, I wouldn't take into account the MELD XI score, namely because there is that risk of HCC moving forward, as well as improvement with the rejection. I firmly believe that the combined transplant just gives this patient the maximum benefit. If you're looking at HCC screening, this patient may be on anticoagulation, may have a pacemaker, and once they're diagnosed with HCC, treatment may be very difficult. MRI would be very limited in patients like this.
Okay. And the second question would, have you found any data on combined heart-liver transplant in these patients and difference in outcome in a center which does a larger volume of combined heart-liver transplant versus centers which do very infrequent combined heart-liver transplant, because the expertise may change outcome? Have you found any data on this?
Most of the data would be single-centered studies, namely from like Mayo, Stanford, UPenn. There is a larger retrospective study looking at the UNOS data by Cotter that kind of compares a larger amount, but it does not always look specifically at Fontan itself. We do recognize that this is a very limited expertise in only certain centers, and as far as experience goes, it is recommended that centers do at least one a year to kind of quote unquote be certified to do this. So it is with limited data, it should still be limited to just specialized centers.
Thank you.
Dr. Malespin or Dr. Kotesh, do you have any questions for the Duke team?
I can ask questions to the Duke team. First of all, congratulations to both teams because you did a phenomenal job. So you made a good point about Fontan causing liver disease without it being a primary liver disease, and therefore reversing histology. And even in this, you can argue that even in the setting of some ascites, you can argue that this may be cardiac related in some patients. But what would be your response if I'm your cardiothoracic transplant surgeon, and then I come to you, ask you, like, could it be child A cirrhosis? And your answer is yes, it can be. And if I ask you, what are the chances? Could it ever decompensate? Could it possibly decompensate? And if so, how would we prevent that? So what would be your assessment so that we don't lose a heart? We want to preserve livers because we are liver transplant people, but at the same time, how do we guarantee to the best of our ability without like a blanket statement that this is not a wasted heart in a patient that can decompensate?
I think that's a great question. I mean, certainly I don't think we can ever guarantee anything, but I think, as you highlighted, this patient has no evidence of portal hypertension. In the VAST study, which we highlighted, patients without portal hypertension were 1/9, the likelihood of having any sort of liver-related event, including decompensation, HCC, requiring transplant. So I think that's one point that we can reassure the surgeons that is some data we do have. And then, as you highlighted, I think this patient is a Child's Pugh A. When you think about risk of surgery in patients with cirrhosis in general, we also know that it's portal hypertension and it's sort of sequelae that make someone high risk for surgery when they have cirrhosis, which this patient does not have. So that would place her just on the lower end of the risk spectrum regardless. So I don't think we could ever guarantee anything, but I think those are points that we would sort of argue would make her certainly lower risk on the spectrum. We do think it'd be totally reasonable to evaluate her for a liver transplant in the event that something unexpected happens. But that's sort of how we would respond to the cardiothoracic surgeon.
Excellent.
As a pretentious cardiothoracic transplant surgeon, I thank you for the consultation.
Excellent. As we conclude debate number 3, we will send a quick follow-up poll to the audience. Based on the presentations, have you changed your opinion on whether or not this patient should be listed for a combined heart-liver transplantation? So this is what the audience felt before the debates. Should the patient be listed for a combined heart-liver transplantation? 62% responded yes, and 38% answered no. And as a follow-up, did these presentations change your opinion on whether or not this patient should be listed for a combined heart-liver transplantation? 47%, that's roughly evenly split. 47% versus 53% replied yes, the presentations did change their opinion, and 53% replied no, the presentations did not change their opinion. As our judges sign off to meet offline to determine the winner of debates number 3, I want to take this opportunity to thank our audience members who have donated to the American Liver Foundation earlier, and to remind our viewing audience that there is still time to make your tax-deductible gift to support the ALF. It's easy. Just go to the Q&A box to make your donation this evening.
All right, thank you. We've heard from 6 amazing debate teams so far. There's just one more debate coming up next. The winners of all 4 debates, plus a People's Choice winning team based on the audience votes, will be announced after the 4th and final debate. So let's move on to debate number 4. Debate number 4 will be judged by Dr. Joe Morelli from the University of Florida, Dr. Tushar Patel from the Mayo Clinic, and Dr. Andrew Keaveney from the Mayo Clinic. Just a reminder, each team is allotted precisely 6 minutes to present their argument and 3 minutes for rebuttal. And following the debate, a 5-minute question and answer session with the judges. If we have time, we'll also take questions from the audience. So I apologize if somebody put in a question and we didn't get to it. The best treatment for a 55-year-old, so debate number 4, the question is the best treatment for a 55-year-old woman with decompensated cirrhosis due to hepatitis C with portal hypertension, MEL score 25, an enlarging 2.5 centimeter cholangiocarcinoma in the left lobe of the liver is liver transplantation. The Medical College of University of South Carolina will present the pro argument, while the Cleveland Clinic, Florida will present the con argument. It's a pleasure to introduce the team from MUSC in the 4th debate. Presenting the argument, the best treatment in this patient is liver transplantation, is the Medical University of South Carolina. The mentors from MUSC are Don Rocky and Ira Wilner. The debate team members are Dr. Shayura Parkash and Dr. John Romano. Presenting the argument that the liver transplantation is not the best treatment for this patient is a team from the Cleveland Clinic, Florida. The Cleveland Clinic, Florida team mentor is Dr. Nakil Kapali. The debate team members are Mamoun Rashid and Mohammed Alamari. Before our debate teams begin, we'd like our audience to answer a quick poll. Based on the criteria I just read, in your opinion, is a liver transplantation the best treatment for this patient? I'll give you guys just about 20 seconds to respond. All right, so we'll begin with Dr. Shayura Parkash from MUSC, who will present the pro position. Timekeepers ready? Let's begin.
Hello, everybody. Thank you for this opportunity. So I will be arguing that for the motion that liver transplant is the best treatment for this patient. Just some brief background. There are 3 main types of cholangiocarcinomas: distal, perihilar, and intrahepatic. And specifically, our patient has intrahepatic cholangiocarcinoma. The diagnosis for this is based on CT or MRI findings. It can be difficult to differentiate from HCC in patients with liver disease and patients with a smaller tumor size. There also appears to be a spectrum of disease from HCC to intrahepatic cholangiocarcinoma, with mixed HCC cholangiocarcinoma being recognized as a more common diagnosis. In general, the management first line is resection if possible. However, this is contraindicated in our patient with decompensated cirrhosis. Other options are radiofrequency ablation, TACE, or chemotherapy for more advanced diseases. So going back to our patient, you're in the hepatology clinic and you've been following this 55-year-old woman with decompensated cirrhosis. Possibly she's already listed for transplant or is undergoing the workup. And now she has this 2.5 centimeter intrahepatic cholangiocarcinoma. So she asks you, will this mean I have to come off the transplant list? And what is the best treatment option for me? So I would argue that liver transplant is the best treatment for her. It gives her the best quality of life, the best overall survival, and the best recurrence-free survival. In general, she already has decompensated cirrhosis. Her MELD is 25, so this has a very poor prognosis. And we know that liver transplant gives her the best survival and the best quality of life. Unfortunately, due to her diagnosis of intrahepatic cholangio, most centers would not transplant her. This guidance to not transplant is based mainly on older studies, which are not really necessarily applicable to this patient. A lot of these older studies showed a 5-year survival of 30 to 35%, which was very poor. However, many of them did not specify the type of cholangiocarcinoma, nor the specific size or tumor burden. When you look at the Milan criteria, HCC had a similar poor outcome with a 5-year survival of 30 to 40% prior to establishment of Milan criteria. Newer studies show much better outcomes. A study in 2016 looked at incidentally found intrahepatic cholangiocarcinoma, 48 patients, and they showed very good outcomes for patients with very early, which they defined as less than 2 centimeters tumor size. 5-year recurrence was 18%, 5-year survival was 65%. And they also looked at a subset of patients with 2 to 3 centimeter tumor size, which would fit our patient. And 5-year survival is comparable in this subset with a 5-year survival of 61%. Another study in 2018 looked specifically at intrahepatic cholangio less than 2 centimeters and also showed a 5-year survival, which was comparable to patients with HCC in their study, 63% versus 70%. The other question is, what is the optimal size cutoff for transplant? And the previous studies looked at mainly less than 2 centimeters, but other studies have looked at less than 5 centimeters. This study in 2020 compared liver transplant versus resection for intrahepatic cholangiocarcinoma, and their patients had a tumor size less than 5 centimeters. First, it's important that it showed that transplant had a much better 5-year recurrence-free survival compared to resection, which is the current standard of treatment, 75% versus 36%. They also looked at specifically 5-year survival and different tumor size, and there's no significant difference between less than 2 centimeters and and between 2 to 5 centimeters, with survival of 69% and 65%. Another study in 2015 had 32 patients, and this was simply looking at patients who were within the Milan criteria, except with incidentally found intrahepatic cholangiocarcinoma. Again, 5-year survival was very good at 78%, and they also compared to matched HCC control group and found no significant difference within the patients who were within the Milan criteria before transplant. So in summary, I would say that transplant is the best treatment for this patient. Currently, it's contraindicated based on older studies, which aren't necessarily accurate. Transplant would give the best overall survival and recurrence-free survival in patients who are appropriately selected. And 5-year survival based on these studies has been comparable to transplant for hepatocellular carcinoma. So I think in the end, this patient should be given the opportunity to get liver transplant as the best treatment for her. Thank you.
Good evening. This is Mahmoud Rashid. I'm a second-year gastroenterology and hepatology fellow from Cleveland Clinic, Florida. So we do not believe liver transplant is the best treatment option for a 55-year-old woman who has decompensated cirrhosis, has enlarging 2.5 centimeter intrahepatic cholangiocarcinoma with a MELD score of 25 and portal hypertension. Initially, when surgery was being done for cholangiocarcinoma, the role of liver transplant was evaluated, and according to the Mayo Clinic protocol, intrahepatic cholangiocarcinoma were excluded from that studies. Later on, some of the studies showed encouraging results for very early intrahepatic cholangiocarcinoma, which is a tumor less than 2 centimeters. One of such studies was published in 2016. This was again a retrospective study, and it was done on pathology of explanted liver. Here they compared very early intrahepatic cholangiocarcinoma, which was tumor less than 2 centimeters, to advanced intrahepatic cholangiocarcinoma with a single tumor more than 2 centimeters or multiple tumors, which is our patient. The authors actually commented on the recurrence rate. The 5-year risk of recurrence for very early intrahepatic cholangiocarcinoma was 18%. This is tumor less than 2 centimeters. And for advanced intrahepatic cholangiocarcinoma group, the 5-year risk of recurrence was 61%, which we are currently discussing the patients. They also found out the 5-year survival rate for very early intrahepatic cholangiocarcinoma group was 65%, and this dropped to 45% in cases of the tumor was more than 2 centimeters for advanced intrahepatic cholangiocarcinoma group. We have multiple studies done back, and all of them shows that the 5-year survival rate for all of them is less than 50%. Some of them they do show that the survival rate can be more than 50%, but on further when we review them, the data analysis, they combine the intrahepatic cholangiocarcinoma with the mixed tumors, which is HCC and intrahepatic cholangiocarcinoma group, which cannot be applied. Now, in order to combine all of these studies, there was a meta-analysis which was just published recently in 2020. It combined 18 studies with total of 355 patients. This was a big population for intrahepatic cholangiocarcinoma. They found out that the 5-year recurrence-free survival for early tumor is 67%. But the patient which we are discussing, the 5-year recurrence-free survival was only 34%, which is not acceptable. The 5-year survival rate for early intrahepatic cholangiocarcinoma was 71%, while this survival rate dropped to 48% in cases of advanced intrahepatic cholangiocarcinoma group. One of other studies which was published in Lancet, this is the only prospective study with a biopsy-proven intrahepatic cholangiocarcinoma more than 2 centimeters. They first treated these patients with the neoadjuvant chemotherapy, and after the tumor was stabilized for 6 months, these patients went liver transplant. So out of 21 patients evaluated, only 6 patients underwent liver transplant. But interestingly, one of 6 patients had cirrhosis. So this study may not be applied to our patient. Although the 5-year overall survival rate was excellent, 83%, it is not applicable to our patient. Similarly, when we reviewed the NCCN guidelines for hepatobiliary cancers, which were just updated recently, for early resectable tumor, they recommend surgery with chemotherapy, or for unresectable and metastatic tumors, they recommend systemic therapy and local radiation therapy. There's nothing mentioning about the liver transplant. It has not made it to the guidelines yet. The best treatment option for them still would be gemcitabine with cisplatin. We also tried to combine the cumulative risk of recurrence and compare the hepatocellular cancer with intracholangiocarcinoma. The overall recurrence for hepatocellular cancer is 10%, but this increased to 36% in cases of intrahepatic cholangiocarcinoma group. And this again mentioning is early intrahepatic cholangiocarcinoma, not with tumors more than 2 centimeters. Now we are currently living in an era where we see every day the patients are being into the liver transplant list. This is the recent list from the UNOS, which says the liver transplant list is actually expanding for general patients. And we are living also the increasing MELD score at listing is being increased for general liver transplant patients. So in current climate for advanced cholangiocarcinoma with more than 2 centimeters, we do not have national guidelines supporting the liver transplant. We suffer from high recurrence rate. We have low survival rates. There's worse outcomes as compared to HCC. We are suffering from critical organ shortage and our wait lists are expanding. So we are very clear in our point. We do not recommend liver transplant for this patient. Thank you.
Again, thank you guys for having us. A few things I would like to point out, starting with the guidelines that state intrahepatic cholangio should not be transplanted. These were based upon very old studies based in the 1980s where modern modalities for treatments were not applicable. Neoadjuvant interventions were not happening at that time. So I'd like to point that, what we're currently basing guidelines on is not to the modern standards. In regards to the CON team's meta-analysis, there was a more recently published meta-analysis that actually came out 4 days ago that showed 2 things that contradict the previous meta-analysis. First, cirrhosis was positively associated with recurrence-free survival in this meta-analysis, which would be applicable to our particular patient. Secondly, in that there was no significant difference in overall survival at 5 years for patients with early intrahepatic cholangio, meaning less than 2 centimeters, versus advanced intrahepatic cholangio, so greater than 2 centimeters. Additionally, a recent study shows that the 5-year overall survival for patients with advanced disease was quoted at 83.3%, and then a residual recurrence-free survival at 50%. This study was notable in that it used kind of the modalities that we would treat HCC patients. They received neoadjuvant chemotherapy, neoadjuvant TACE, and other modalities that are similar to what we see with HCC treatment. So I'd like to close in saying that current guidelines are outdated. They do not take into account all of the interventions that we have at our disposal. And thus, we would advocate that our particular patient would be appropriate and successful with transplant if current interventions were taken before and after transplantation.
Thank you. And now Dr. Mohammed Alamari from Cleveland Clinic, Florida will rebut MUSC's argument.
Good evening, everyone. So the available literature about our topic is nicely summarized by the Ziogas et al. Meta-analysis, which actually came in 2020 and had a very good quality of evidence in it, as they did a very good meta-regression analysis with a reasonable heterogeneity, less than 25%. And it mainly came from small and retrospective studies. And actually, they excluded all the patients who had combined intrahepatic and perihilar cholangiocarcinoma. And it only proposed liver transplant in cirrhotic patients with very early intrahepatic cholangiocarcinoma, less than 2 centimeters, and in the context of a UNOS-approved research protocols. Actually, this is not surprising to us in the era of organ shortage, as even after perfect selection of those patients, the 5-year survival rate is at least 15 to 20% lower than it is in HCC patients undergoing liver transplant. It is also crucial to know that those studies specifically noted the size of tumor at the time of transplant rather than presentation, as in our case. So considering the enlarging tumor as indicated in the vignette stem and the long transplant waiting time, high likelihood that tumor will be even bigger at time of surgery. And actually that's in line with the Lee et al. Study from Mayo, Jacksonville, as they show that those tumors are typically understaged. And talking about the society guidelines and oncology guidelines, actually the International Liver Transplant Society report from 2019 was in line with the NNC guidelines, and they only proposed liver transplant in very small intrahepatic cholangiocarcinoma. So I really don't think they are outdated. And I have a few points to mention about the studies cited by our colleagues. I'm glad they mentioned the French study by Dumartin et al., but I don't think they highlighted that only included 14 patients with large intrahepatic cholangiocarcinoma, and they had low MELD with a median of 12. And the results were confounded by significant follow-up dropout, which led to selection bias, as mentioned by the authors themselves. Most importantly, when they did the multivariate analysis, actually they combined the histology of HCC and intrahepatic cholangiocarcinoma. The other studies they mentioned, by Facchito et al., actually only 7 patients were cirrhotic. And again, when they did their analysis, was combined HCC and intrahepatic cholangiocarcinoma, I think just to reach a statistical significance. So all these studies actually were included in the meta-analysis. And the overall results were in favor of liver transplant only in those who have very early cholangiocarcinoma. While unfortunately this patient has very limited options, the evolving molecular profiling and targeted therapies and new adjuvant local regional therapies for downstaging could be potential options. And finally, as we follow guidelines and evidence-based medicine in day-to-day practice, the evidence is currently lacking, and large intrahepatic cholangiocarcinoma remains a formal contraindication to date.
Thank you to our debate teams. Both did a great job. And now let's take questions from the debate number 4 judges panel. Welcome to our debate 4 judges panel, Dr. Morelli, Dr. Patel, and Dr. Kiani. Also, special thanks to Dr. Kiani, who stepped in at the last minute when we had a judge who was not able to join us. Who would like to ask the first question?
I can take that. So thank you again to both of the teams for that, the excellent presentations and discussions. So I'll start out with a question for the MESC team. A key issue that was brought up by your opponents was the issue of recurrence. And in the study by DeMartin that both the teams actually quoted, the risk of recurrence was based primarily on pathologic features rather than size. So question for the MESC team, should we be considering performing a biopsy if that hasn't already been done to assess for differentiation prior to making a decision?
I'll take this one. I think that's certainly a reasonable consideration. We know that HCC and cholangio are essentially a spectrum of disease, and it's often very difficult to distinguish what we have. And obviously, a majority of the time for HCC, we're not doing a biopsy, we're diagnosing that with quadruple phase images. There are theoretical risks of biopsying a liver lesion, but I think that if the suspicion is high for cholangio, it's certainly not an unreasonable task to talk about risk benefit with the patient and pursue a biopsy to optimize targeted neoadjuvant and adjuvant therapies prior to any type of surgical or transplantable intervention.
I have a question for the MESC presenters. An excellent presentation. Thank you for your excellent presentations. Realistically, are you aware of data that a patient with decompensated cirrhosis, a MEL score 25, would be able to tolerate any kind of neoadjuvant therapy? You emphasize the importance of modern therapies, but what data are there that patients with advanced cirrhosis can tolerate such neoadjuvant therapy?
I don't have any specific data for this particular patient population, but I know that it's really going to depend on what is driving their MELD score and what manifestations of decompensation they have. If it's primarily bilirubin driven, I think you're in a more difficult boat. But let's say this patient has coexisting kidney disease, I think that it would be easier to pick suitable regimens that are non-nephrotoxic, and they would be more tolerable for this particular person.
Before we wrap up debate number 4, we'll send a quick follow-up poll to the audience. Based on the presentations, have you changed your opinion on whether or not liver transplant is the best treatment for this patient?
As the judges for debate number 4 enter their deliberation session, let me remind you that the American Liver Foundation is hosting academic debates across the United States. There are 6 remaining academic debates between now and the end of 2021. Please visit the ALF's events webpage, alfevents.org, to connect with these events and register to attend. There are debates across the entire country: Texas, Arizona, Utah, Texas, Rocky Mountain, Colorado region, Greater Pennsylvania, Greater DC, and Michigan. Before we announce the winners of the 2021 Southeast Academic Debates, in just a couple of minutes, we need your help in determining the People's Choice winner of the events. We have one more audience poll.
All right. I hope everyone was able to make a selection for our People's Choice overall winner. The ALF has a YouTube channel dedicated to videos for medical professionals. This Southeast academic debate program will be uploaded to this site in a few days. I encourage you to explore the ALF website, liverfoundation.org, and encourage your patients to use the ALF as a trusted resource for liver health. As a reminder, ALF has many resources for the liver patient, including the helpline, and we offer exceptional educational programs to our healthcare professionals. We invite you to connect with the ALF on social media. Please like us on Facebook or follow us on LinkedIn, Twitter, and Instagram. Thank you. On behalf of the American Liver Foundation, my co-chair and co-moderator, Dr. Raj Satyanarayana, congratulations to the 8 debate teams on an outstanding job. Thank you to their mentors for the expert guidance, the judges on their thoughtful questions, and the ALF tech team and the audience for joining us this evening. Dr. Satyana Rayana, would you like to add anything else?
I agree. All of the teams have performed exceptionally well this evening and deserve to be recognized. Thank you for sharing your countless hours of research, elevating our understanding of these thought-provoking topics, and devoting your time to improve patient outcomes. This has been a very stimulating debate session overall, and I'm sure it's generated a lot of questions in our young debaters' minds, as well as some of our mentors and judges as well. And now I think we are ready to announce the 4 debate winners and the People's Choice winner. The winner of debate number 1, featuring the University of Florida, Gainesville, arguing the pro position, and the Mayo Clinic, Florida, arguing the con position. 65-year-old gentleman with hepatitis C cirrhosis complicated by ascites requiring paracentesis every 2 to 3 weeks, and hepatic encephalopathy requiring hospitalization 3 times in the past 6 months, despite compliance with lactulose and rifaximin, who has a MELD score that is stable at 17 with a median MELD at transplant at the center where he is listed of 25. He is hepatitis B naive. He should be listed for HPV DNA, hepatitis B surface antigen positive donors. And the winner of this debate number 1 is the Mayo Clinic in Florida.
All right. Congratulations to the Mayo Clinic in Florida. The winner of debate number 2, featuring University of Florida, Jacksonville, with the pro position, and the University of Miami with the con position. The 7-year-old man with alcoholic cirrhosis and portal hypertension with a MELD score of 15, non-bleeding grade 1 esophageal varices, but without ascites, developing an obstructing sigmoid colon adenocarcinoma. He should undergo transjugular intrahepatic portosystemic shunt prior to undergoing colectomy. The winner of this debate is the University of Miami. Congratulations.
Debate number 3, featuring Emory University adopting the pro position and Duke University the con position. 26-year-old woman with a history of congenital heart disease who has undergone Fontan procedure as a child, now presenting with failing Fontan physiology and is an acceptable candidate for heart transplantation. However, imaging shows she has a nodular liver, but no signs of portal hypertension. Biopsy confirms stage 4 fibrosis. She should be listed for a combined heart liver transplantation. And the winner of debate number 3 is Duke University.
Winner of debate number 4, featuring MUSC with the pro position and Cleveland Clinic, Florida, with the con position. The best treatment for a 55-year-old woman with decompensated cirrhosis due to hep C with portal hypertension and a MELD score of 25 and an enlarging 2.5 centimeter cholangiocarcinoma in the left lobe of the liver is a liver transplantation. And the winner is Cleveland Clinic, Florida. Congratulations. Also to all of the debate team members, within the next few days, you should be getting feedback from the judges themselves in order to help you guys continue your learning process.
And the People's Choice winner, and this is among all the debate teams, is Duke University. They garnered 56% of the votes, followed by the Cleveland Clinic, who garnered 24% of the votes.
Congratulations to all the debate teams. In reality, everyone wins tonight: the healthcare community, patients, caregivers, and the general public. Thank you.
Thank you for joining us to support the American Liver Foundation. Stay healthy. That concludes the event. this evening. Thank you for joining us, and I hope you had a stimulating evening.